She came in for a hip replacement. 71 years old, retired school librarian named Dorothy, sharp as anyone I'd ever met in clinical practice. Crossword puzzles every morning, book club every Thursday, no signs of memory trouble whatsoever. Her surgery went perfectly. 90 minutes, no complications, textbook case. But 3 days later, her daughter called the office. Dorothy was confused. She kept asking what year it was. She thought her husband was still alive, and he had been gone for 6 years. By 6 weeks post-op, she had recovered most of her baseline function. But there was something missing, a sharpness that had been there before, a quickness to her thinking that never fully came back. Dorothy's surgeon called it a successful surgery, and technically he was right. But what happened to Dorothy in that operating room, and in the hours and days after it, is something that almost nobody talks to older patients about before they consent to go under. And today, I am going to change that. I am Dr. Pablo, a board-certified geriatrician with 18 years of clinical experience, and the majority of my patients are adults over 60 who are facing surgery, sometimes elective, sometimes urgent, and almost none of them have been given the complete picture of what general anesthesia actually does to a brain and a body that has been on this earth for 6, 7, or 8 decades. This is not about frightening you. I want to be absolutely clear about that from the start. Millions of older adults go through surgery every year and come out the other side just fine. But informed consent, real informed consent, means you understand what is actually happening inside your body when those drugs go in. And right now, most of you do not. So, let us fix that. Here is the first thing you need to understand. Anesthesia does not work the same way in your body at 65 as it did at 35. That seems obvious when you say it out loud, but the implications run deeper than most people realize. Your liver processes drugs more slowly as you age. Your kidneys clear medications at a reduced rate. The blood-brain barrier, the protective membrane that separates your bloodstream from your brain tissue, becomes more permeable with age. And your brain itself, the organ that anesthetic drugs are specifically targeting, has already undergone years of microscopic structural changes that make it more sensitive, more reactive, and slower to recover. The anesthesiologist standing over you is making calculations, dosing decisions, based partly on your weight, your medical history, your current medications. But age changes the pharmacodynamics of almost every drug in that room, and that matters enormously for what happens to you after you wake up. Let us start at the beginning, because I want you to understand the full sequence of what happens. Before the main anesthetic is given, you will typically receive what is called premedication. In many hospitals, this is midazolam, a benzodiazepine, the same drug family as Valium. It calms anxiety, and critically, it causes something called anterograde amnesia. Your brain stops forming new memories. You may be having a full conversation with the surgical team, answering questions, even signing paperwork, and later you will have zero recollection of any of it. For younger patients, this is largely a temporary and benign side effect. For adults over 60, particularly those with any existing mild cognitive impairment, even the kind that has not yet been formally diagnosed, benzodiazepines carry a meaningfully elevated risk of triggering confusion that can last well beyond the operating room. The American Geriatric Society has placed benzodiazepines on what is called the Beers criteria, a formal list of medications considered potentially inappropriate for older adults. And yet they remain routinely used in pre-surgical settings across this country, without a word of warning to the patient about why that matters specifically for their age group. Then comes induction. The anesthesiologist injects propofol, a white lipid-based drug that patients sometimes call milk of amnesia, directly into your IV line. It burns as it travels up the vein. Many patients describe the sensation as fire moving up their arm, and then, within 8 to 10 seconds, consciousness is gone. Not dimmed, not reduced. Gone. Your eyes roll back, your muscles go slack, your breathing stops. The anesthesiologist is now breathing for you, manually at first, squeezing a bag mask over your face to push oxygen into lungs that are no longer working on their own. Then, a laryngoscope goes into your mouth, a curved metal blade with a light, and a plastic endotracheal tube is threaded down through your vocal cords into your trachea. You are now connected to a ventilator. A machine is breathing for you, and you have also been given a neuromuscular blocking agent. Rocuronium or succinylcholine are the most common, which has chemically severed the communication between your nervous system and your muscles. Your brain can send signals. Your body will not respond. You are, in the most clinical and literal sense of the phrase, temporarily in a state that shares more physiological characteristics with death than with sleep. I want to pause there because that framing matters. We use the word sleep because it is reassuring. Patients ask, "Will I be asleep?" And we say yes because the alternative, explaining what is actually occurring, takes longer and frightens people. But general anesthesia is not sleep. Sleep is an active neurological process. Your brain cycles through distinct stages. Memory consolidation happens. Cellular repair happens. During REM sleep, your brain is nearly as active as it is during waking hours. General anesthesia is the pharmacological suppression of consciousness itself. Researchers at the Massachusetts General Hospital have shown on functional MRI that under adequate anesthesia, the integrated information processing that defines conscious experience simply ceases. The prefrontal cortex becomes disconnected from the rest of the brain. There is no dreaming, there is no experience, there is no awareness, there is just nothing. And then you come back. But here is what I need you to understand about that return, specifically if you are over 60. Emergence from anesthesia, the process of waking up, is not simply the drug wearing off. It is your brain reestablishing its functional architecture. And in older adults, that process is slower, more vulnerable to disruption, and carries risks that can persist for weeks or months after you leave the recovery room. The most concerning of these is something called Post-Operative Cognitive Dysfunction, POCD. It is not well named because dysfunction sounds temporary and minor. What POCD actually means is a measurable, documented decline in memory, attention, executive function, and processing speed that follows surgery and anesthesia. A landmark study published in the Lancet followed patients over 60 who underwent major non-cardiac surgery. At 1 week post-operation, over 25% showed significant cognitive decline. At 3 months, nearly 10% still had not returned to baseline. And in patients over 75, those numbers were substantially higher. Dorothy was not unlucky. Dorothy was statistically predictable. The mechanism is not fully understood, but the leading hypothesis centers on neuroinflammation. Surgery triggers a systemic inflammatory response, your immune system activating as it would for any significant bodily trauma. In younger brains, the blood-brain barrier largely contains that inflammatory cascade. In older brains, where the barrier is more permeable and the baseline level of neuroinflammation is already higher, surgery-related inflammation can penetrate directly into brain tissue. Microglial cells, the brain's immune cells, become activated. They release cytokines, and those cytokines disrupt the same synaptic processes that support memory formation and cognitive clarity. This is why POCD is not just a drug effect. It does not simply clear when the anesthetic clears. It is a biological process that has been set in motion, and it runs its own timeline regardless of how smoothly the surgery itself went. Now, there is another condition I need to raise with you before we go further, because it is even more acute and more immediately alarming than POCD, and it affects roughly 30 to 40% of older adults admitted to the hospital for surgery. It is called post-operative delirium. Not confusion in the soft, disorienting sense. True delirium, agitation, hallucinations, complete disorientation to time and place, combativeness, terror. I have had patients in the recovery unit who were completely lucid going into surgery and who came out genuinely believing they were somewhere else, in another decade, surrounded by people who were not there. Post-operative delirium typically peaks in the first 24 to 72 hours after surgery. Most cases resolve, but research published in JAMA has shown that post-operative delirium is independently associated with accelerated long-term cognitive decline, meaning patients who experience it are at elevated risk for developing dementia at a faster rate than they would have otherwise. A frightening surgery in a frightening hospital room is not just an unpleasant memory. It may be a biological inflection point in the trajectory of your brain health. I want to tell you about Gerald. Gerald was 74, a retired electrician from outside Columbus, Ohio. He came in for a routine laparoscopic gallbladder removal, 45 minutes under general anesthesia, no complications on the table. By evening of the same day, his wife was at the nurse's station asking for help because Gerald thought he was at a construction site and could not understand why his wife kept trying to make him lie down. He was frightened. She was terrified. The nursing staff recognized post-operative delirium and managed it appropriately. Reorientation, minimizing sedating medications, getting him to a window with natural light, bringing in familiar objects from home. By day 3, Gerald was back, fully oriented, joking with the nurses, ready to go home. But his wife told me privately that she had seen something in those 72 hours that she could not entirely forget. A glimpse of a version of her husband she had hoped would never arrive. And Gerald himself said quietly that he did not remember any of it, and that somehow made it worse. The risk factors for post-operative delirium that you should know about, and that you should discuss openly with your surgical team before you ever walk into that operating room, include advanced age above 70, pre-existing mild cognitive impairment even if undiagnosed, poor preoperative sleep, dehydration, polypharmacy meaning taking 5 or more medications simultaneously, poor vision or hearing that goes uncorrected during hospitalization, and certain classes of anesthetic and pain medication including, again, benzodiazepines and high-dose opioids. None of these risk factors make surgery impossible or even inadvisable in most cases, but they are variables that a proactive, informed patient can help manage. You can ask your anesthesiologist about regional anesthesia alternatives where appropriate. You can ask about TIVA, total intravenous anesthesia, versus inhaled gas, because some evidence suggests different inflammatory profiles. You can ask that your hearing aids and glasses be with you the moment you wake up. You can ask for a window room. These are not small asks. These are evidence-based protective interventions, and you have every right to make them. Now I want to talk about your heart, because cardiac risk during anesthesia in adults over 60 is something that is often undercommunicated in preoperative appointments that are, frankly, too short and too rushed to cover everything they should. General anesthesia causes significant cardiovascular changes from the moment induction begins. Propofol is a vasodilator. It relaxes the walls of your blood vessels, which causes blood to pool in your extremities and your blood pressure to drop. For a 40-year-old with a healthy cardiovascular system, this is manageable. For a 68-year-old with any degree of arterial stiffness, diastolic dysfunction, or left ventricular hypertrophy, conditions that are common and often asymptomatic in this age group, the hemodynamic shifts of induction can be dramatic. Blood pressure that drops too far, too fast, reduces perfusion to the heart muscle itself. In a heart that already has any degree of coronary artery disease, even subclinical disease that has never caused symptoms, this reduction in perfusion pressure can trigger what is called a myocardial injury after non-cardiac surgery, or MINS. A study published in the European Heart Journal found that MINS occurs in approximately 8% of patients over 65 undergoing major non-cardiac surgery, and the majority of those patients had no cardiac symptoms beforehand. 8%. That is not a rare event. That is a common event that is simply not being discussed at the bedside. Your anesthesiologist is managing these swings in real time. Vasopressors to bring pressure back up, fluid boluses to support cardiac output, continuous EKG monitoring to watch for ischemic changes on the rhythm strip. But the point is that the system being stressed is yours. And if your cardiovascular system has any pre-existing vulnerability, anesthesia creates the conditions for that vulnerability to become a clinical event. This is not an argument against surgery. In many cases, surgery is life-saving, and the cardiac risk is worth taking. But it is an argument for preoperative cardiac evaluation, an EKG at minimum, and in higher-risk patients, a formal cardiac risk assessment using validated tools like the Revised Cardiac Risk Index before the consent form is ever signed. There is also the question of temperature, and I raise this because it is almost never mentioned to patients, and yet it has real physiological consequences for older adults. Operating rooms are cold, intentionally cold, typically between 60 and 65 degrees Fahrenheit, because lower temperatures reduce bacterial growth and extend the window of safety for certain surgical procedures. But when you are unconscious and paralyzed, your body cannot thermoregulate. You cannot shiver effectively. You cannot redirect blood flow to your core. General anesthesia suppresses the hypothalamic thermostat, and in older adults who already have reduced thermoregulatory capacity compared to younger patients, unintended perioperative hypothermia, a core body temperature drop below 96 degrees Fahrenheit, occurs in a meaningful percentage of cases when warming measures are not actively employed. Hypothermia increases cardiac arrhythmia risk. It impairs coagulation. It slows drug metabolism, meaning the anesthetic drugs stay in your system longer than expected, extending the recovery period. It increases surgical site infection risk by impairing immune function at the tissue level. Warming blankets, fluid warmers, and OR temperature adjustments are standard precautions, but they require that someone is actively prioritizing them. You can ask before surgery whether forced air warming will be used throughout your procedure. That is a question worth asking. I want to stop here and ask you something. If you are 60 or older and watching this, I want you to write your age and where in the world you are watching from in the comments below, because the conversation I am having with you right now is one that I believe every older adult deserves to have before surgery. Not in a rushed pre-op appointment 15 minutes before a procedure, but thoughtfully, with enough time to process and to ask questions. I want to know who is watching, and I want you to know that you are not alone in navigating this. Let me now tell you about something that the original research community is beginning to take very seriously, and that the public has almost no awareness of yet. It is the relationship between certain anesthetic agents and the acceleration of Alzheimer's-related pathology. Laboratory research in cell cultures and animal models has shown that both isoflurane and sevoflurane, two of the most widely used inhaled anesthetic gases, can promote the aggregation of amyloid beta protein, the same protein that forms the plaques characteristic of Alzheimer's disease, and can enhance the phosphorylation of tau protein, which forms the neurofibrillary tangles that destroy neurons in Alzheimer's brains. These are in vitro findings. The translation to human clinical outcomes is not yet definitive, and I want to be careful not to overstate the evidence. But a 2021 meta-analysis in the British Journal of Anesthesia found that patients with a known genetic predisposition to Alzheimer's, specifically those carrying the APOE epsilon-4 allele, showed greater cognitive vulnerability following surgery under general anesthesia compared to non-carriers. If you have a family history of Alzheimer's disease, if you have undergone genetic testing that has identified APOE epsilon-4 status, this is information your anesthesiologist should have before selecting your anesthetic regimen. It may influence whether an inhaled agent or a purely intravenous approach is preferable for your specific case. I am not telling you this to create panic. I am telling you this because the question, what kind of anesthesia will you use and why, is one that you are fully entitled to ask, and almost nobody asks it. I want to tell you about one more patient. Her name was Carol, 67 years old, a retired pediatric nurse, which meant she understood medicine well enough to know exactly what questions to ask and was not remotely intimidated by clinical environments. Carol came to me before a scheduled knee replacement, not as a patient, but as someone who had done her research. She had read about POCD, she had read about delirium, she had a family history of Alzheimer's on her mother's side, and she had been genetically tested. She carried one copy of the APOE epsilon-4 allele. She sat across from me and said, I want to understand every variable we can control. Tell me what we can do to protect my brain. And I want to tell you what I told her, because it applies to every one of you. We discussed the option of spinal anesthesia with light sedation for her knee replacement, which would avoid general anesthesia entirely and reduce central nervous system drug exposure substantially. We reviewed her pre-operative medications and identified two that significantly increased delirium risk. We coordinated with her primary care physician to hold those medications in the perioperative period. We scheduled her surgery for the morning, first slot, because fatigue and longer nil-by-mouth periods increased delirium risk. We made sure she would have her glasses immediately upon emergence. We requested a room with a window and arranged for her husband to be present as quickly as possible after she moved to the floor, because familiar faces and voices are among the most powerful reorientation tools we have. Carol had a smooth recovery. She was cognitively sharp at her 2-week follow-up. She credited the preparation. I credited her for knowing enough to ask. That preparation is available to you. It requires that you know what to ask. And now you do. Here is the practical framework I want you to carry into any preoperative appointment. First, ask your anesthesiologist whether you are a candidate for regional anesthesia, spinal, epidural, or nerve block, for your specific procedure, and whether that would reduce your systemic anesthetic exposure. Second, ask whether your premedication plan includes benzodiazepines, and given your age, whether that is specifically necessary. Third, ask about intraoperative brain monitoring, BIS monitoring, or similar EEG-based depth of anesthesia monitoring, which allows the anesthesiologist to titrate drugs more precisely, avoiding both awareness and oversedation. Fourth, ask what the post-operative pain management plan is, and whether high-dose opioids can be minimized through multimodal analgesia, combining non-opioid pain relievers, local anesthetic blocks, and anti-inflammatory medications. High-dose opioids are one of the most significant drivers of post-operative delirium in older adults. Fifth, if you have any personal or family history of cognitive decline or dementia, disclose it explicitly. It changes the risk profile and should change the anesthetic approach. Sixth, ask about the plan for early mobilization after surgery, because the single most powerful intervention for preventing post-operative delirium is getting patients up and moving, ideally within hours of arriving on the surgical floor, not the next morning. Here is what I want you to understand about all of this. The experience of going under general anesthesia, the moment consciousness disappears, the gap where you simply no longer exist as an experiencing being, and then the return, is one of the most profound physiological events a human body can go through. And in an older body, that event carries a specific constellation of risks that deserve specific, honest, unhurried conversation. Not a form signed in a waiting room, a real conversation. The good news, and there is real good news here, is that the field of anesthesiology is moving in exactly the right direction. The concept of brain protective anesthesia for older adults is gaining traction in major academic medical centers. The Society for Neuroscience in Anesthesiology and Critical Care has published guidelines specifically addressing cognitive outcomes in elderly surgical patients. Research institutions from Johns Hopkins to University College London are running prospective trials on anesthetic selection and long-term cognitive trajectories. The science is catching up to what clinicians like me have been seeing at the bedside for years. But right now, in the gap between what the research says and what the average pre-operative appointment covers, there are millions of older adults walking into surgery without the information they need to advocate for their own brains. You are not one of them anymore. Dorothy is doing well. She found a new rhythm. The sharpness came back in different ways, she told me, even if it did not come back exactly. She still does the crossword. She still goes to book club. But she told me she wished someone had prepared her for what might happen, so that she and her family would have known what they were seeing and known how to help her through it. I think about that often. I think about the difference between a frightening unknown and a difficult thing you understand and have prepared for. That difference is everything. If you are facing surgery, any surgery requiring general anesthesia, please share this video with the people who will be in that waiting room for you, because the people who love you deserve to understand what is happening inside you too. And if this gave you something you needed, knowledge you did not have an hour ago, please subscribe to this channel, because this is exactly what we do here, every single week. The truth about what happens inside your body as you age, delivered without condescension, without shortcuts, and without anything left out. You have earned the right to know, and I will keep telling you.